Hello, everybody, from our comfortable seats in Cambridge, Massachusetts. Welcome to all of you from all around the world. I know that many of you are deeply engaged in supporting community health workers, and many others of you are here to learn and consider some of the issues. So it is with great pleasure that we are going to have an hour to speak with Dr. Rajiv Shah, president of the Rockefeller Foundation, and Dr. Raj Panjabi. We're going to have a name challenge here. Who is the founder of Last Mile Health. My name is Stephanie Dodson. I am a managing director at Draper Richards Kaplan, where we find, fund, and support early stage social entrepreneurs. I am delighted to be with both of you today. So just to introduce you to our speakers today, Dr. Rajiv Shah, who is currently president of the Rockefeller Foundation, was in a leadership role at the Gates Foundation for many years, and then was the USAID administrator. He was actually unanimously brought into that role, which is shocking in itself. That alone is a life accomplishment. And his focus at the agency was to revamp a lot of the work there to focus on innovation, focus on results, and public-private partnerships. So he brings a lot to the table at the Rockefeller Foundation. Dr. Rajiv Panjabi co-founded Last Mile Health. That was 10 years ago to save lives in the most remote communities in Liberia and soon to be other places. He has gotten great recognition for the phenomenal work he's done. He's been Time 100 Most Influential People in the World. He won the 2017 TED Prize to start the Community Health Academy and was listed as one of the world's 50 greatest leaders by Fortune in 2015-2017. And this year, which we will hear more about, he, together with Last Mile Health, together with Living Goods, is doing an audacious project, which is very audacious. We'll hear more about that. So, and most importantly, in case I get sick, we have two doctors on the stage. So we will be closely monitoring the screens. We'll be able to answer a couple questions along the way. So please do send those in. We're curious to hear what you're thinking about. And maybe we could begin with this. How did the two of you begin to work together?
Well, it's a great question. Thank you, Stephanie, for being here with us, and to you, Raj. I don't know, maybe our parents destined it with the coordination and the names, but we actually started working together before we met each other. It was in September of 2014. The Ebola epidemic, many will remember, was spreading like wildfire in West Africa. We had already lost many people in my country where I'd grown up, in Liberia and in Sierra Leone and in Guinea. And around that time, and Raj remembers this very well, I'm sure many will, there was a gentleman that had come through to the US in Dallas, Texas with Ebola, and that made it very real that there's this threat here as well. That very week, the New York Times released this report from the CDC that said there could be as many as 1.6 million cases of Ebola, that many of those patients would die, and that this would spread if nothing more was done. And I was on the ground with our team. We were training local frontline health workers in the forest where a woman had come, having not been able to access a treatment bed in the capital, had fallen sick with Ebola. A few weeks later, 14 people who attended her funeral had died with the virus, and a number of us were trying to support the local government to respond. And one of the agencies that was just absolutely critical in this was USAID, the U.S. Agency for International Development. And thankfully for all of us, Raj was at the helm of that. Not only did more aid through its Office of Foreign Disaster Assistance needed to be deployed, more money to train more workers, to get the stuff in, to get the treatment units built, but you needed a sort of all-in government response. And Raj spent a lot of time with President Obama getting many parts of the government, of the US government, involved. And as we know, luckily those 1.5 million-ish cases never came to pass. And a lot of it, I have to say, is thanks to the leadership of many groups, but especially Raj and what the US government did at that time in support of the local ministry. So that's how we first started working together. And then as the epidemic ended, the government, in very strong leadership moments, said, look, actually it was 2 days before the crisis ended, said, we're going to train and equip and hire thousands of frontline health workers in rural areas where these epidemics tend to first start. Part of that vision is making sure community health workers are supported. And at that time, the Rockefeller Foundation, along with USAID, committed a grant to Last Mile Health to work with the government and a number of other partners to put that program forward. And we can talk a bit about later about what's happened since, but that's how we first started working together.
Yeah, I was on the other end of some of those phone calls. And I mean, my task in government at the time was to help support President Obama and our team to contain and fight back against an Ebola crisis that had already infected thousands and at the time killed several hundred people, including a large percentage of the trained workforce in the health sector in Liberia. And we advocated for, and ultimately the president was very strong about his science-based decision-making to deploy American military personnel in support of the effort to dramatically expand our humanitarian fight to fight and beat Ebola, to keep connectivity and airplane routing going so we could actually prevent further spread. The president made some tough political calls at a time when it was pretty heated politically. But my task in that moment was also to find like superheroes on the ground who, you know, at a time when the mortality rate for people working to address the health crisis of Ebola in Liberia was easily 60 or 70%. I mean, it was well north of 50%. You know, it was hard to find people and institutions that would say, okay, I can take that risk and go in and interact with high-risk communities. And we found Raj and Last Mile Health. There were others as well who stood up, but history doesn't often thank the folks who are on the ground taking the personal risk to do something that has a huge humanitarian consequence. And so I'm glad to be able to say thanks today.
I'm sure the two of you are bonded for life. That was really quite an experience. So, you know, community health work is getting a lot of attention these days, and it is one piece of a big global health system and not a panacea. I'm curious for the two of you, how do you define community health?
Well, maybe I'll start because Raj has the actual answer, and I'm just thinking it through. But at the end of the day, we've, you know, actually when the Rockefeller Foundation was founded in 1914, a large part of the inspiration was the idea that medicine should move away from a commercial, you know, snake oil sales kind of environment to a science-based discipline housed and advanced by medical institutions and research and academic hospitals. And for decades, we built those institutions here in the United States, including right here at Harvard and all around the world. I actually think we're on the cusp of a new era where healthcare delivery will be, especially in settings like this one, managed much more proactively by having an Apple Watch or a Fitbit that is monitoring your health, connected to, you know, data-driven, algorithmic-based services that can come in and provide effective prevention or chronic disease management outside of a hospital or a medical setting that seems like a more advanced care setting. And in doing so, it can empower a lot of people to take control of their own health. And ironically, we see that same concept defining and redefining health outcomes for very low-income people in lower-income countries all around the world. So, you know, our definition of community health is really if you can have families take more responsibility for their own health care. Are their kids vaccinated? Do they have access to simple support when a child gets diarrhea or pneumonia? Are mothers being born in an assisted setting where there's a trained assistant, not an OBGYN, but a trained assistant that can reach them? And where we've seen those types of community health advances reach people who otherwise don't get services, we've seen a rapid reduction in maternal mortality and child mortality and infant mortality. And that's why we're so excited about expanding access to modern data-driven community health all around the world.
Yeah, and modern data-driven community health is such a wonderful vision so timely at this moment, because community health has been, when you put something as powerful as healthcare in the hands of communities, um, especially when healthcare, as Raj mentioned, for the last 100 years has been sort of defined as this sort of reserved for a guild, right? We're sort of reserved for doctors or nurses. There's something else that goes with that thinking sometimes, is that if it's in the hands of the community, maybe it's not as real. Maybe it's not as modern. Maybe it's not as impactful. And I think all the science has shown in the last 40 years that that's not the case. That some of the points and trends Raj is making, that whether it's the everyday crisis or it's the acute type of Ebola crisis, one way or another, communities aren't just a nice to have in the response, they are a need to have. And so the way we define it is not that different. I think for us, it's about communities not only participating but leading. And maybe just, I'll give you an example. I've always found that's helpful in trying to define it. Is I was just came off talking with a colleague of mine, Ben Grant, who's working, he's a Liberian physician assistant who's helped mobilize a community called Bo, which literally means far off place in Liberia. And the reason it's named called that is because about 100 years ago, a group of hunting families went into the middle of the forest looking for new places to hunt game. And they settled about 2,000 people across 9 villages, about 34 miles apart in the middle of the forest over the last 100 years. Well, they've been really great at subsistence living. They have managed to do a lot in those communities, but they've never had any healthcare. In fact, a century went by, they had no access to healthcare. So we've made these marvelous innovations in modern medicine, and antibiotics, anti-malarials. You have access to ultrasound technology to provide prenatal care, but these have not reached last mile communities like Bose. So, what Ben and his colleagues did after the Rockefeller Foundation, USAID, and a number of others put in this investment in the Liberian government, they said, look, we're going to take this National Community Health Assistant Program, which employed, hired, and equipped thousands of workers across the country, including Bo. They said, we're going to train neighbors. About 12 of them were trained as these so-called community health assistants. That required a nurse being put in to coach those workers. And for the first time, this community saw what they thought were curses when their children died from malaria and pneumonia. What they thought were impossible things to change, like mothers having been hoisted on hammocks and branches, sort of makeshift hammocks as they're called, where you take a lapa cloth, put 2 branches together, and hoist a mother in the middle of obstructed labor to try to go 20 hours to the nearest hospital, only to perish. That's what they knew as the circumstances of health and disease. But now they saw these community health workers treating these children for malaria, pneumonia, diarrhea. They saw the mortality rate drop. No child's died in that community for the last 3 years. About 10 were dying every year in that community. And they've said, look, we need to go even further. And so they worked with the nurse and the community health workers. They learned that birth planning was important. They learned that giving birth in a clinic was important. And so they together came forward with the idea to build a community health clinic, a community health post. And so imagine, with this investment in I think that's how we know whether these investments matter, what community health can be. It's when people start demanding something better than they had before. And it's being driven locally. I think that's what it means, and I think what the potential is, especially when you add now modern data-driven approaches.
Okay, can I add to that? I mean, Raj, you guys announced recently this audacious goal of reaching 34 million additional people, I think, in 6 countries.
Yeah, with our colleagues at Living Goods, right?
Yeah, in East and West Africa, right?
Right?
And that's so important, and it's so important because the story you just told is super powerful, because you can imagine what that's like in one specific community in Bo in Liberia. At the same time, when you look in 1990, we had 12.6 million children under the age of 5 who died of simple diseases. Today, we have 6 million. And that's way, way, way too many. But it also is remarkable progress in just lifting up the living standards of the world's poorest and most vulnerable villages and communities all around the world. And now we believe that by 2030, we can basically be pretty close to zero, as the Sustainable Development Goals have identified that target. And so if we work with urgency, if we are quantitative and serious about expanding outreach, if we measure and track results as they do in Ethiopia and certain parts of India and as you do in Liberia, and if more people can help you guys scale up significantly, we can actually do something that's never been done before, which is ensure that basically every child born on this planet, no matter how poor, no matter how difficult a circumstance, gets to experience a fifth birthday. And while that's an extraordinary moral and human outcome, that's also been shown to be the key to changing demographics and educational outcomes for kids and allowing communities to move up that pathway of economic success and join a modern global economy. So this is such an important enterprise, and I'm glad you played an important personal role in helping Last Mile Health get off the ground many years ago. Deserve a lot of credit for that. And there are thousands of people, if not hundreds of thousands, that are part of this movement, and our goal is to ensure that it succeeds.
Well, and Stephanie, I'm wondering if we could even talk a bit about the idea of a movement and would that be all right? Raj, you said something really interesting at the Council of Foreign Relations. I think it was a few weeks ago, perhaps. You made a point about how the child survival revolution was largely about, one of the lessons from it was that institutions put their own agendas aside so they could all commit behind a bigger goal. And I'm wondering, as you think about a modern data-driven approach to community health, I mean, how does that lesson, how might it look here? I'm thinking in part about what you said. I'm also thinking about the science being so ripe. Back then, the science was ripe around, only a handful of conditions. You had growth monitoring and ORS. The science has now dramatically improved. I mean, I think that this recent paper from Hopkins, Henry Perry and colleagues found that if community health workers were trained and equipped to do at least 30 services, from maternal child health to HIV, TB, we could save at least 2.5 million lives a year. That's a conservative estimate. It's 30 million lives by 2030. I mean, the data seems really right, but how do those two things, movement and data, matter now? And how might it?
Well, I'm going to come back to you asking more about the science piece.
Yeah.
But I took away. I used to have the luxury of having an office near Bill Fagie's office inside the Gates Foundation, and Bill is such an extraordinary human being and is appropriately recognized as such. But he would constantly refer to the child survival movement and the Committee on Child Survival in the 70s and 80s as a vehicle that brought together leaders from big institutions, the World Health Organization, CDC, USAID, country ministries, and served as a forum where people, instead of sort of advancing their institutions' goals or frankly, beating their chests about what they were achieving, would come together and say, what do we really have to do to solve a problem in a more dramatic way? Like, what does it take to get oral rehydration to everybody? What does it take to get vaccination rates up? And his point to me then was, if we can build that kind of a culture within our global health and community of saying, let's just work together and be honest about where we're succeeding, where we're not succeeding, and solve problems in a more selfless way, that's how you get coverage rates from 30% to 50% to 80%. And wherever I've seen that happen, it's been remarkably successful. Ethiopia is a case Bill Gates likes to articulate and has written about, where just taking a data-driven approach to in every village, do we have community health workers that are reaching people? Are they collecting data on kids are vaccinated, kids have access to oral rehydration, kids sleep under bed nets, kids with diarrhea or pneumonia can go see someone in a clinic? You cover those basic things, and all of a sudden you see a steep reduction in children dying unnecessarily when they're young. You see a steep reduction in mothers that perish during childbirth. You see improved outcomes on education and nutrition. and you start to see a society that now has been growing at 8 or 9% a year for more than a decade. So what I take away is we have to build that culture of working together. And you've done that really well with Last Mile Health, because everybody wants to support Last Mile Health for obvious reasons. Part of that is you are so compelling personally. Part of that is the track record you've built. And part of that is just the sense that, hey, we should all be in this together. Because if we can get community health workers, millions of community health workers around the world, to add a few additional tasks to their list of to-dos and maybe have technology that makes it more effective for them to provide services, we can achieve this extraordinary goal.
Yeah, I think you had linked that to, and Stephanie, you and I have talked about this, the importance of metrics and data and philanthropy in general. And you I think in that same talk talked about how the way people get inspired about going further together is by seeing that data more clearly. And that just really hit home, because just this morning, everything we've done in Liberia is really a credit to the government of the country moving forward, the communities like Bo, also the partners that are teaming up. And we just recently, the new Minister of Health, Dr. Jala, and the current Deputy Health Minister wrote a piece in the British Medical Journal around the World Health Assembly. And as we wrote about this piece, the question was, how do you build a community health system in a country? How do you make sure it's high quality? This connection between data, being seen, targets being agreed to, and the data coming in, switch partnership forward. And there were about 4 or 5 nonprofit organizations that had helped the government agree that we'd have one plan to shift from volunteer unsupervised to clinically supervised to get the density up in rural areas. And there was a set of funders, including the Global Fund. Should I pick that up? Okay. But the Global Fund, USAID, UNICEF, the Global Financing Facility, and a few others said, look, we're going to come behind this single plan. So it took the government saying we wanted to write a new plan. The plan was 4,000 workers, 400 nurse supervisors, covering extending care to the last bit of the 4.5 million people in remote areas. And they also then this coalition committed to come together once a quarter to review the data against that plan, which meant somebody had to build the information systems that showed how many kids were visited. Is the expected result correlating with the actual result? I'm wondering, Raj, I mean, is that the kind, when you think about the dynamic, because we've seen it, that people are more excited if they can see the progress. The programs now increase coverage rates for malaria, pneumonia, and diarrhea by 50% in some of these remote rural areas. It's increased facility-based deliveries in a few districts. We were just reviewing the data up to 84%. And that's the kind of stuff that's getting people excited. But is that how, when you've seen it, is that how it feels, looks?
Well, it is. And frankly, you can't improve. I think it's hard. Let me put it this way. It's difficult to improve what you can't measure. And so having simple, observable measurements like, births in a facility where women get some assistance, or tracking immunization rates in a rigorous way, or measuring the incidence of diarrheal disease and understanding, where the next set of cases might come. That's the basic health systems information that I think we need in order to manage to success. And I suspect when you started looking around and getting interested in last mile health, originally that focus on data and information was probably a part of it.
Right. It was my colleague Brendan Cullen who was on Raj's board when all of this Ebola crisis broke and you scaled up overnight. And I remember thinking about how much had to happen without yet the technology infrastructure. So I'm curious, beyond the data, which is so critical, what other role, and I know this is a big focus for Rockefeller as well, what other role will the technology play? Like, can you kind of paint us a picture of what that's going to look like?
Well, last mile health is kind of on the front end of experimenting with this. So I'll also, Raj, you should speak to it.
Sure.
But we just see a lot of promise. So, for example, there are groups now that can use predictive analytics to identify vulnerable households in a much more granular way. the Rockefeller Foundation works in agriculture, for example, just as much as in health. And we have a team that, using geospatial data and AI algorithms, can identify which household in a village is more likely to adopt seeds and fertilizer and use those inputs to improve their productivity and then their nutrition and their welfare, and which ones that could be neighboring ones are less likely to do so. And that's an extraordinary tool. I don't know if we're there yet in health, but we ought to be able to cheaply collect enough information and use, freely available geospatial data and other kinds of information to build those algorithms in health, so that when a community health worker goes into a village in Senegal, they should be able to know which households should they go to first, because the children in those homes or the women in those homes are more vulnerable than other homes. And it's precisely in areas of work where we don't have the ability to reach 100% coverage right away, that targeting and efficiency becomes important. And I think of it in very simple terms. If I am interested in getting a pair of shoes, even before I get on my phone or my computer, like look up a pair of shoes, I feel like I see ads for the exact shoes that I want. So someone out there knows, my preference for shoes. And when I'm thinking I might need a pair of shoes, and is bombarding me with super targeted information. If any of you like superstar data analytics people that do that marketing work are watching, we need your help, because we need that skill set applied to saying, where is the next child going to get diarrhea and die in this community? And if we had that pinpoint specific information, we'd be able to save those lives. And that's what we know from Ebola. Like as dire as those circumstances were, and the CDC said 1.6 million people might contract Ebola at a time when the mortality rate was over 50%. At the end of the day, 30,000 people got Ebola, and I think 11,000 people died, and that's way, way, way too many. But the reason it wasn't higher than that is that Hans Rosling and Johns Hopkins and Harvard sent all these epidemiologists, great people on the ground that were willing to collect and share data and information, started to identify where is there a case, and based on knowing exactly where that case is and in which village, we could send teams that would go out there, help do the quarantine work and help do the work to prevent transmission in that setting. And all of a sudden we saw the transmission rate go way, way down very quickly. That same sense of urgency around data and response needs to be applied, because look, we don't call it a pandemic threat when 6 million kids a year die, but we shouldn't pretend that it's not an urgent problem that we can and should solve.
That's right. I that very much resonates. I just building off the theme of predictive analytics, I think that's absolutely one of the key areas, and you're absolutely right to invite. It's going to be people with those skills teaming up with those in the health system that are going to transform our ability to, really bring healthcare within reach of everyone everywhere. And it's so relevant right now. You look at this national program. The number one reason the government put it in place, the National Community Health Worker Program in Liberia, was to ensure, the first thing they got trained on was the CDC's global protocol on identifying what they call community event-based surveillance. 13 things that might be infectious disease threats of public health importance. Everything from potential Ebolas or viral hemorrhagic fevers to unexplained deaths amongst humans or animals, to meningitis, measles, polio. Every community should at least have that basic surveillance monitored. In the last 8 months, since the program's trained these 3,000 plus workers, they've identified 1,700 potential infectious disease triggers. And I use the word potential because some of those have been true, some of those have not been. And you can imagine that if you help those workers with that data set get better at predicting which one of those things were true positives rather than false positives, you'd have a much better, more efficient system. And then I think it's important, as you were saying, on the everyday crisis, right? That same group of workers now has conducted about 500,000 visits in the last 8 months. Again, places that never had healthcare before, like Bo. And so there's a lot there that we can understand about the disease burden. And then there's a lot that then needs to be done. I think a lot of it, I still see patients in Liberia from time to time. I think a lot about it from the quality of care perspective. And I know you share that being a trained physician as well, is that these workers are 6th to 12th grade educated. And just think about Bo, the one woman I think of there is Ajua. Ajua is 19. She was trained in 6 months to be a community health worker on the national curriculum. It was infectious disease surveillance, but it was also treating children for malaria, pneumonia, diarrhea. It was screening children for malnutrition. It was preparing birth plans, following patients with HIV and tuberculosis. Well, the first patient she saw, one of the first patients in her neighborhood, was a 70-year-old man named Albert who had heart failure and had high blood pressure, had gone undiagnosed and untreated for a long time. And the Ministry of Health stuck in this very big dilemma, which is, I know there's a burden of non-communicable diseases like high blood pressure or hypertension. That man unfortunately died despite there being treatment for his cause because it had gone 10, 20 years, even though he had someone there that could have helped him. Now, the Ministry of Health is stuck with, well, how many tasks can you give a 6th to 12th grade educated person? And you and I both know we can go down to CVS and get our blood pressure taken. So one, we need to make sure her smartphone's equipped with those peripherals, or she herself is taught. To teach her that skill is going to require making sure she's coached by a nurse, comes back for the training. But the phone can also be, and we've started to do this now through the Community Health Academy. The ministry's asked if we would digitize some of the curriculum. There's great videos on how you can take a blood pressure. That's not, you don't drop a parachute with a phone in a community like hers and teach her. It's just not how she's going to learn. But if she's coached by a nurse a couple of times a month, in the meantime, and you and I have this, continuing education, you can use the phone to show the video of how you take a blood pressure. You can take a quiz to see if you've actually demonstrated competency. And the whole Ministry of Health can then assess more clearly which skills are being mastered and which aren't, so that when you want to add the next skill, it's just a lot easier to argue. There's no reason a community health worker who can dose a liquid antibiotic, amoxicillin, which is typically used, can't do a blood pressure monitoring. You and I would never go to a clinician that says, I can't do a blood pressure, but I'll treat your 4-year-old or your infant with antibiotics, because that's a harder thing to master, much more dangerous consequences than getting the blood pressure right. So I think what I'm most excited about, in addition to the predictive analytics, is the ability for technology to make the quality of care much more transparent. I would argue that if you looked at the competency of community health workers around the world, not a single ministry could tell you in real time how competent those workers are. But every ministry wants to do that. And it's very hard to get that data unless you have a tool that can produce a dashboard that can tell you. And I think advancing this quality of care, responding to what I think is a quality crisis in community health, is going to be critical, and I think technology is going to enable that.
I'll just add, I'm glad you mentioned the CVS example. CVS buying Aetna is, in my view, kind of demonstrates that that a lot of people believe the future of community health is as relevant here or in Europe as it is in Liberia or rural parts of Bihar in India. And everyone should, I think our view is everyone should get to participate in that future. You shouldn't have to live in an advanced industrial country to benefit from the fact that data, science, and technology can now empower a community worker or a mother or a father to lift up and care for the health of their family and community in a way that you simply couldn't do 10, 15, 20 years ago.
And I think you have touched on this a little bit, but I'm wondering if you have anything to add to the idea that I think the Ebola crisis is over. You can tell us if there's anything we still need to worry about there.
The one in West Africa from a couple of years, but
okay. But how do we capture people's attention? Why are they going to care about just the regular burden of disease?
Yeah. You mean in settings that
in settings that are not their own?
Yeah.
You know, why am I sitting here in Cambridge, Massachusetts? How are you going to make that case to me?
I mean, talk about someone with wisdom on that question.
I don't know about wisdom, but well,
Congress unanimously voted you in.
Yeah. No comment. Look, I think at the end of the day, I'll tell you one thing I learned in government was that this doesn't have to be a partisan issue. There are people on both sides of the aisle politically who believe in the very simple idea, whether it comes from your morality or your faith or your understanding of how societies develop and how economies become strong, that when we lift up those who are literally the most vulnerable, we are making our country and our community stronger and safer. And that's just been proven time and time again. You know, conflict emanates from places where they are fighting over water and food and trafficking in guns and people. And in fact, when I was in government, we worked with the Department of Defense and tracked voluntary family planning services and found across the Sahel, 17 countries in West Africa, and found that in fact places that had very low access to basic health services, including family planning, including community health, including agricultural support, tended to have much higher rates of crime, of trafficking in guns, in people, and higher rates of conflict, especially cross-border. I was struck during the Ebola crisis by how, for the first time for me professionally, it seemed like everybody got it. Everybody was so interested. Like I went, you were there, but I went and did a tour of the three countries, Sierra Leone, Liberia, and Guinea, in, I guess it was early October. And I came back and spoke about the trip on CNN and some other news outlets, and then went, and even all the parents in my kids' school, observed that I had been gone doing that, and everybody wanted to know, first, was I safe to be near, and was I going to the soccer game that weekend? And second, like what was happening? Because everyone had a sense it is so important that we use our capacity to be humanitarians effectively to save lives there and to protect us here. And they felt and saw that connection in a way that was so visceral. I don't actually know how to continue to build that sense of connectivity, but we have to do it because there's another Ebola crisis right now taking place in the Democratic Republic of Congo. 70% of the new pandemic threats come from animal to human transmission. A lot of surveillance capacity gets lost because of gaps in community health capabilities and surveillance capabilities in the poorest places in the world. And building up a capacity to just do modern surveillance for pandemic threats like Ebola in the toughest to reach, poorest parts of the world is something that keeps us safe right here at home. Doesn't cost that much, costs a couple $2 billion a year at most, and would be extraordinarily protective for the entire planet, helping us protect against the kinds of pandemic threats that could knock 10-20% off of global GDP and result in the deaths of millions and millions, tens of millions by some estimates, people. So these are small preventative investments, and we just have to keep making the case.
Yeah, those are, just so well said. I think the moral argument is there, right? Everyone should have access to healthcare. My child, who happens to be here in the audience, as you might hear online, gets healthcare. The child in Bo should too. The child in Liberia and Bihar should. I think the point you made about security is so clear, right? I mean, I think it was Tom Frieden or someone, the previous CDC director, who said disease anywhere is a threat to people everywhere. That's not, again, those two things happened at the same time. I remember talking to Judy Woodruff about this at Aspen last year, that the very day that gentleman walked into the hospital in Dallas with Ebola, that very, I think 2 or 3 days around is when the CDC said there could be 1.5 million cases. It's not theoretical. And we know that from Ebola, which is a zoonotic disease, as that's from animal sources, of course, spreading human to human, which is why the healthcare for humans is so important. But so is Zika. Zika started in the Zika forest of Uganda. So is HIV, it turns out, which started in central parts of Africa and went decades before being detected. I mean, imagine, had there been workers earlier, I'm not saying that no one could prove whether that would have stopped it, but could it have halted the suffering? Could it have slowed the pain? Could it have helped us become faster at enabling the treatments needed? Could fewer people have lost their lives? Yes. Could have more businesses preserved their businesses because they, in the case of Ebola, what was it, about $2.2 billion of economic loss. There's $5.6 billion of aid, taxpayer money from here that went just to try to stop the epidemic. Too many of our people's lives lost. So I think that's a key argument. And I think the last one that I've found, like you, is what you said earlier about CVS, is that it turns out that we can do something about it. And if we try to do something about it in a place like Liberia or Bihar or Ethiopia, that can teach us about how we could transform healthcare here at home. I'm on the faculty of Harvard Medical School here, and I was just giving a talk to Mass General Hospital last week, but the data I was drawing from was not Liberia alone, it was Alaska, where they've put in a program for the last 60 years, and they've figured out, they learned it initially from abroad, from the Chinese, and they trained local women to do dentistry care, amongst other things. And, initially there was resistance. American Dental Association sued them because and the Alaskans said, you know what, we'll show the science, shows they're safe, effective, they're being remotely monitored through telemedicine. And by the way, 40 vacancies for dentists had been in place for about 40 years, and nobody came to fill them. Now they have dental care for every kid in rural America, in that part of rural America. So I through community health workers that are backed up by dentists in remote settings. But think about how much access, cost, and quality just got dramatically changed by that example. And right here in the city, across in Chelsea, Massachusetts, the other example that we were talking about was the fact that the Mass General Chelsea Health Center had managed to, with populations in that community, improve the cervical cancer screening rate amongst minority populations where there are a lot of language barriers, because they employed those minority populations who knew the language to be so-called patient navigators, which is just a different form of a community health worker. Now women are coming in with lower grade cervical cancer. So I think that, to me, and I think we're just touching the edge of the surface. I think it's going to take the Rockefeller Foundations, who are working on initiatives beyond global health, on cities, et cetera, and leaders like you just helping us figure out where this could go, this cross-learning.
Yeah, it's so beautifully said by both of you. It really does give you a sense of the movement involved in this. We have some questions.
Great.
So let's just take a couple of those. Pratik Ahuja, thank you very much, from India. The question is that in India, they've trained quite a few community health workers, and there have been some issues with the technology training for them. But the real challenge lies in hiring and retaining these workers. Why is the question?
Well, first, thank you for the question. I'll say of the 6 million children who die every year under the age of 5, unfortunately, still the country that has the most under 5 child deaths is India. Whether it's 900,000 or a little bit higher, a little bit lower, is debatable, but it is the most of any other country on the planet. So India has a huge opportunity. It turns out most of those child deaths happen in about 130 or so districts in India, and that the government has now partnered with local philanthropists like the Piramal Foundation or the Wish Foundation in order to help hire, train, support, and put the right kinds of technology in place so that community health workers can be more effective in those settings. And I think that's a great trend because, these philanthropists became successful as good managers and built big businesses, and now are showing a commitment to working in public-private partnership to reach that very last mile and serve those communities that have been hardest to serve. And I think we're going to learn a lot from their work and their deployment of new technology and new solutions in that system. I've just found, especially in India, this is true everywhere in the world, the single biggest thing one can do or has to do in order to drive success is care about it at the highest levels and measure the outcomes, identify where there are gaps in the system, and then put resources and management effort and focus on solving that.
Sounds so simple.
Yeah, it's not the world's most complicated task, and I mean, folks like Raj bring a lot of energy to doing it in tough places, but it's not a super complicated task. And now that the data is and the analytics are getting better and better, it should get even more manageable to solve it. And that's partly why we shouldn't accept the basic idea that, oh, it's okay somehow if 6 million kids a year die because they were born into poor households in poor parts of the world, because that's just the way it is. It doesn't have to be that way if enough people join the effort.
Yeah, and I think this was really well said. He says pratik, is that right? Is this the pratik? I think that the other piece of this is also what you said about getting folks to care about it, is to shift the norms somewhat, right? I mean, most community, you said retained and on the job, the volunteer model is something that we need more volunteers for sure. And there's a group of community health workers that are going to be formally part of the health system who also deserve to be paid as any one of us would. And that's it's a fine thing to say morally or ideologically, but it's so much smarter to do it that way. The Liberian government shifted from volunteers to paid workers. They pay $70 a month, and they got 500,000 visits. They got 50% increase in malaria, pneumonia, diarrhea treatment. They found the potential next Ebolas. That's just that trade-off from a public health perspective makes a lot of sense. I know the World Health Organization is looking at this with their new guidelines about whether they're going to start recommending pay. The truth is right now, at least in Africa, most are still semi-compensated or volunteer. I don't know what the case is in India. I know some are compensated. But I think then this to me is where then the data comes in, because if you're going to pay for that, the technology makes it a little easier to know what you're getting in return, because you can see the lives being, the visits happening, you can see the workers being trained. And I think the last thing is just, technology gets such a bad rap at times for stealing jobs. This is a place where technology can create jobs at a time when jobs are really needed. As you said so beautifully in almost every setting, certainly rural areas of India, Africa, urban areas of both parts of the world. And I think that if we can create jobs, what a wonderful way to grow an economy, by investing in service delivery jobs amongst a group of people that otherwise may not be employed. You can create tons of jobs that way.
Philip, thank you for this question. How important is it to leverage digitally empowered community health workers to ensure the civil registration of births and deaths?
Yeah, I'll be brief, very. I mean, not only that, but also the census. I mean, we've found settings where the census is off by a decent number, and equipping. I mean, we're not here to be the census body for Liberia, but when you have a ratio in Liberia, it's about 350 people per community health assistant. You really know those 350 people. You know where they are, whether they exist, whether they migrate or not. So I think it's really critical for the denominator even of that number. And I'm sure you have thoughts on this as well.
Yeah, I suspect at least some in the audience would be surprised to know that doesn't already happen, right? That births are routinely not registered, deaths are routinely not captured. And if you don't identify that basic information, it's extraordinarily challenging to serve a population without knowing that. I'd point you to, there's an example in India where they have 1.2 billion people have biometric identification through a system called Aadhaar. And just to give you a sense of how in the United States, sometimes we believe it's controversial to have an ID card or a public, although I have a driver's license and a passport, so I'm over that concern. But not everyone is. But in places, I've met people in rural parts of India who never had their births registered, who never had a formal identity, who couldn't get basic services because they weren't official. They didn't officially exist. And when Aadhaar came along, they would migrate, or they would travel, 50, 60, 70 kilometers to go to a station where they would register. And they tell these stories about how powerful it is to feel like you now have an identity, you now exist. And I think that's another example of technology that's going to bring more people into the system. Once you do that, you can be much more effective at serving a population because you know where they are.
So related to that, are there concerns around privacy breaches that have to be considered in that?
I think so, and there should be, right? Because data, as we see, there's no system in the world that collects data and information in which privacy is not an important concern. In India, with Aadhaar, there have been data security breaches that have been the subject of real debate and genuine concern and real improvement in the security and management of that system. We're here in the United States and we're on Facebook, so we know that it's not like we're immune to that in this country. And just because we place data security in the hands of a private firm, theoretically, because we hit I accept on a 40-page disclaimer, that doesn't guarantee data security either. So dealing with how we secure data and build public infrastructure to manage data in the future is a task every country on the planet will have to deal with. And I'd say no one's got it right. No one's got it entirely wrong just yet. Probably. Or shoes.
Shall see.
Yeah.
Okay, so an organization named Healthcare Ready, I'm curious what that is, from Washington, D.C. asks, how can we leverage digital empowerment of community health workers to improve our disaster planning and disaster response, especially when it comes to making healthcare more resilient?
Well, I imagine you also have a lot to say about this, Raj, especially with what I think your first days on the job, you involved in the earthquake in Haiti.
Yeah.
Is a key part of it. I just a quick sounds working. Oh yeah. So I think one way that we've noticed is through mapping. In Liberia, the remote rural parts of the country, many of the places lack bridges or they lack, cellular infrastructure. So I think one is mapping, work that a colleague is doing out of Mount Sinai. Prabjot Singh is working on this thing called Atlas. And I know many others are working on these sort of mapping technologies. How do you ground truth? What isn't being seen at resolution by satellite? So I think that's really important as a first step in disaster preparedness. And Raj, I'm sure you'll have other things to add.
Yeah, I mean, it depends on where you're talking about. So obviously, mapping is really critical. But we have a global humanitarian response system set up for large-scale disasters and humanitarian crises. We don't have that same system set up for pandemic threats. And that's why after the Ebola crisis, there were 4 or 5 major studies to say, well, how do we build a more resilient system? How do we build a capacity to respond at times of crisis more effectively? The good news is all 4 or 5, I think one came out of Harvard, one was the Institute of Medicine, one I was a part of was Ban Ki-moon asked me and a group of others to join a panel to evaluate ideas. One came from Chancellor Merkel and Bill Gates. The great news is they all had the same basic recommendations. It was have a standby, ready to go, rapid response capacity sitting somewhat alongside WHO. Have rapidly deployable financing to put that in place quickly. Build stockpiles of vaccines and expand the early research around preventative solutions. And expand dramatically the investments in community health and community surveillance of those types of diseases and improve lab capacity in country after country. Those basic findings all together really only cost a couple of $2 billion a year to implement on a global basis, and we still haven't done it. And so I'd say the first thing we need to do for disaster preparedness overall is just learn from the Ebola crisis, learn from the Zika crisis, and be much more aggressive about putting that in action. And we can start there.
Okay, I think we have time for one more question. I'm curious about this. So we know that $1 of investment in community health workers results in $10 of improvement in improvement in the economy, and that an enormous amount of money was spent around the globe in addressing Ebola. So there is an economic piece of this that makes a lot of sense. And we also saw through Last Mile Health, Rockefeller, USAID, and lots of other players that it really took all sectors together to get our arms around the Ebola crisis. So just a little bit from both of you on where you see the role for the for private industry, for foundations like Rockefeller, and for obviously organizations like Last Mile Health. And governments, of course.
Sure. Yeah. I mean, and thanks for bringing up that report, because I don't think enough's been made of that data, and it was actually a conservative estimate. I had the chance to work on that with a number of others, but the Liberian president, the Ethiopian prime minister at the time, all came together thanks to work that the Financing Alliance for Health and a number of others were doing to pull that report together. But and that comes through healthier, productive life years, jobs created, epidemics averted. So I think the private sector has a need to be involved in all of those, right? I mean, if you're a health system in the private sector, you can hire a lot of these workers. It'll probably make healthcare more accessible, higher quality, lower cost. If you're not in the health sector, let's think about mining communities and some of the areas we work in. You want your workers to have less malaria. Less malaria means less sick days at home, and it means healthier, productive life years for your workers. The last thing is the epidemics. I mean, I think that you want to be involved. That there was an interesting group, and I think, Raj, your team, when you were at AID, helped with this quite a bit. It's called a private sector alliance on Ebola. A lot of the companies that typically otherwise may not have worked together, when Ebola came to the front doorstep, brought forward logistics, vehicles, and a number of other their own hubs at rural sites involved in actually responding to the crisis. So I think there's both the everyday work and the emergency work. But you've been thinking about this for a lot longer than I have. What else would you add?
Well, look, I think community health is not just it's not just a topic and an area of investment for very low-income communities. It is in distal parts of the world. It is really a defining trend for how healthcare will evolve here at home and in every community and country on the planet. And the reason for that is the data, the technology, the analytics, the capacity to leverage high-skilled, highly trained medical professionals with technology to reach many, many more people than they otherwise would have is just going to transform the way healthcare is provided, whether you're in Western China or downtown Detroit or rural Liberia. And our task is to really help people see as these trends take hold. Too often we watch the trends happen in industrial countries, and then 20, 30 years later, we get around to really getting immunization rates up in lower income settings. We need to address this the other way around. We need to start with lessons learned from Ebola and dramatically expand community healthcare in the most difficult to reach parts of the world. We need to deploy artificial intelligence algorithms to do diagnostics and, in some cases, care and treatment in places where you can do that, and then learn from that and import some of the findings here at home. And so I think that's a great study, and I think it's important for people to realize that what's underlying, the basic underlying point is when you find the communities that don't have access to a healthcare system and you use highly leveraged community health to reach them and you lift them up, you're doing a great service to that local community, but also to the larger economy. And ultimately, I know from my last job, to the national security of entire countries. Mm-hmm. So this is for what it costs, a no-brainer. But if we don't stick together, if we don't fight aggressively, if we don't make the case in a compelling way, it's not going to just happen on its own.
Thank you. This was fabulous. And I just want to say an enormous thank you to both of you for the leadership that you're providing in a way that is opening this up for so many people to participate. I do think this is indeed going to take a movement with a lot of parties involved, and both of your leadership on this has been phenomenal. So thank you.